Hi everyone, thank you for asking me to come and talk today. My name is Bristi and I'm a respiratory physician at Westmead Hospital. Can everyone hear me? So I learned a lot while making this talk that there's not much in the way of evidence regarding beyond case reports that is regarding pulmonary problems and sleep problems in osteogenesis imperfecta. But what I will go through is what the common reported lung and sleep problems are, why we put you through all the tests that we do, some of which might seem like a little bit of torture, and also the treatment options. So lung disease can manifest in lots of different ways in OI. In more severe forms, you can get maldevelopment of the lungs or pulmonary hyperplasia. More commonly, you can get restrictive lung disease due to various chest wall problems or sometimes even intrinsic problems in the lungs due to collagen. Depending on any skull-based problems, you can also get airway obstruction from bony defects and basilar impression, as Professor Lentz mentioned before. And upper airway problems can also result in sleep apnea. Thoracic cage problems can also result in another type of sleep apnea called central sleep apnea, or even sleep hyperventilation, where in sleep you underbreathe, which can result in carbon dioxide levels slowly going up when you sleep. And finally, your lung problems can also affect your heart, and you can get something called pulmonary hypertension, where the blood pressure running through your lungs ends up being high, and that can contribute to breathing problems and shortness of breath. And there's a relationship between the risk of getting lung disease and the severity of OI that you have. So in terms of restricted lung disease, essentially this is just a fancy name for when your lung volumes are reduced. And as I mentioned previously, the most common causes are having problems with your chest wall, so kyphoscoliosis and vertebral collapse, which results in loss of height of your spine, but also squashes your lungs. Having rib fractures can also be a problem because it affects the way you breathe, and also pain from fractures can result in the inability not to deep breathe. But there's also pulmonary collagen abnormalities as well. So there's lots of collagen in lungs, and if you have any problems with collagen, this results in abnormalities of the lung where they can't expand properly and can't contract properly. And if you have any problems with taking deep breaths, or you've had chronic lung collapse because of chest wall problems, you can get recurrent infections in those areas. And more infections can result in more lung collapse and scarring in the lungs as well, which can only make your restrictive lung disease worse. So how do we test for what kind of lung problems you have? We like to do lots of radiology. I'm sure every time you go to hospital, someone might try and do an X-ray. And X-rays done over time are useful in monitoring what your lungs look like. And CT scans, which are a little bit more radiation, give us more information, not only in terms of do you have an infection, how squashed your lungs are, how big your heart is, but it can also tell us what's going on in the spine. And finally, we like to do breathing tests called spirometry, which I'll go through, and also more formal lung function tests where we put you in a creepy glass box and tell you to do some breathing exercises. And finally, as I mentioned, because you can get pulmonary hypertension, an ultrasound of your heart is sometimes useful, especially if your breathing has changed or gotten worse and your lung function is exactly the same. It might not be predominantly a lung problem causing your symptoms. So radiology is very useful in telling us if it's a chronic problem or something that's been going on in a long time, or is there something completely different in your X-ray, and that's why you're suddenly more breathless than usual. And that could be an infection, so you might see a pneumonia on an X-ray, or new lung collapse. And more chronic changes that we monitor over time include the shape of your thorax or your chest. Has your upper airway changed, or has it become more distorted? Or is it suddenly that your heart is much bigger than it was, say, 1 or 2 years ago? So this is an X-ray of one of our patients with OI. And I'm just going to go through all the changes that we sometimes see, and some of the changes that we monitor over time if you get an X-ray year after year after year, for example. So what you can see is that this curving of the spine, this is only a front film, so you can't see the kyphosis per se, but you can see definitely the scoliosis or the curved spine. You can see cardiomegaly, which just means that the heart's very big. So a normal heart would be probably half of that size. And you can see atelectasis, or a little bit of white in the corner, where the rest of the lung is nice and black because air on an X-ray turns up as black. So there's a little bit of lung collapse there. And finally, with spinal abnormalities, what you can get is your tummy gets a little bit squashed, and that increased pressure ends up also squashing your lungs. And in this person, there's a little air bubble in the middle of the lung fields that shouldn't be there. And this is a hiatus hernia with the abdominal pressure having squashed the stomach upwards into the chest wall. And when we see something like this, we often like to follow it up with a CT scan to give us more information about what might be going on in terms of contributors to someone's breathlessness or lung problems. And what we can see here is you can see the scoliosis again, so the curvature of the spine where the vertebral body is pointing sideways instead of upwards. Lung collapse or atelectasis, which is this little band of white where lung otherwise would be black. And finally, with what I had mentioned with the hiatus hernia, it's quite severe, and that increased intra-abdominal pressure from the squashed abdominal contents has actually resulted in not just stomach but bowel loops also taking up this person's chest cavity. So you can imagine that lungs, this is the right lung and this is the left lung, if you can see my cursor. No, you can't. No. Okay, I'll just point. So right lung, left lung, usually they're twice the size of that. So this person's big heart, their scoliosis, and also the hernia that's in their chest cavity is all contributing to lung collapse, squashing the lungs, and will result in reduced lung function in this person. So how do we measure? Basically, we want to measure the severity of someone's lung restriction. And what we want to do is compare it to previous values. So you want to see if over time things are changing or getting worse. And sometimes it helps you also assess if there's other things going on, such as asthma on top of their OI. And in the future, if there's a reduction in lung function, it predicts for complications, such as if your lung function is starting to drop below a liter, for example, you're at higher risk of conditions such as hypoventilation or respiratory failure, and a higher risk of conditions such as pulmonary hypertension. So when people get you to do a spirometry, which is the machine where you've got the mouthpiece and you have to make a really good mouth seal, and essentially they ask you to take a deep breath in and blow out really, really hard, which is sometimes quite hard to do. We test for two things, something called an FEV1, which is your forced expiratory volume in 1 second. So how much of that deep breath you can get out in that 1 second. Most people should be able to get out 80% of their breath in that first 1 second. If you can't, you might have asthma. And the second thing that we test for is something called a forced vital capacity. So what volume you can get out forcefully by the end of expiration. And with people with OI, if they've got any restrictive lung disease, it's the FVC that will slowly drop over time. And this is what we end up monitoring. So spirometry is quite simple to do. You can just do it in a doctor's room. But if your spirometry is unusual or if it's dropped off over time, then what they often get you to do is lung volumes. So they get you to sit in a little glass box and they close the door. So if you're claustrophobic, it's not a very fun test to do. But they can measure something called total lung capacity, which is the maximum volume of air you can fit into your lungs, and then all the smaller lung volumes on top of that. And that gives us more parameters to monitor. And over time, either we can see if your total lung capacity remains stable or if it starts reducing over time. And the other test they'll get you to do is breathe in a mixture of gases to see whether your lungs allow the transfer of oxygen that you breathe in into your bloodstream as well. And that's a test called the DLCO. So they'll get you to breathe a mixture of helium and carbon monoxide. It's not enough to make your voice squeaky or change. And what they do is see how much of that carbon monoxide gets from your lungs into your bloodstream. And if your lungs, if the lungs are normal enough, that is, there's not lots of collapse, you don't have the condition called pulmonary hypertension, this number will come back normal. But if it comes back low, it tells us that maybe the collapse or maybe your degree of lung disease is starting to cause other problems. So the problem is that all these lung tests rely on predicted values. So what they get compared to is someone else, your gender, someone else, your age, someone of a similar ethnicity, and it takes into account whether you've taken any Ventolin, for example, and also whether you smoke. But the other thing that it needs to take into account is your weight and your height, which becomes difficult in some people with OI. So spirometry and lung function testing is often not accurate in people with shorter stature. And what we often use in people who are of short stature or people who are in a wheelchair where you can't accurately measure height is arm span. However, if you've had arm fractures in the past and you can't stretch your arms out, that makes it difficult again. Now, if you pick the incorrect height, so if you pick a smaller height because you've decided to measure someone from the end of their wheelchair to the head, which is not correct, but I've seen people do it, you might get a normal lung function reading when you actually have quite severe disease because they're comparing you to someone of that height, which might be 120 or 100 centimeter person. And again, if they just estimate your height, so they pick a larger height than you actually are, you might get an abnormal lung function reading and have to go through all these other tests when you've only got mild disease. So what do we do to try and overcome this? We try and do baseline lung function when a person is old enough to do reproducible tests, and that's usually in early teenage years. And then you continue to monitor lung function after that using the same technique that you use to obtain their height, which is usually arm span, and then closely monitor not just the predicted values, but the actual absolute values. So I've got some interesting lung function of people with OI. So the first one on the right-hand side is a person who was labeled as having obstructive lung disease based on their lung function test. And the reason it's obstructive is because what you can see is there's a FEV1 to FVC ratio that says it's 75%. So for this person's age, weight, height, gender, their ratio comes as obstructive because that ratio is low. And the total lung capacity ends up being normal. It's 75% predicted, so anything that's red is abnormal. And their DLCO, so their ability to get oxygen across their lung membrane, is also normal at 87%. This is lung function of a person who was reported as having lung restriction or squashed lungs, for example. And the reason this is because the ratio, so the FEV1 to FVC ratio, ends up being normal for this person at 75% when you compare to their age, weight, height, ethnicity, and gender. And their TLC is only 42% predicted, so it's severely reduced. And their DLCO is also normal. If you look at this person's absolute values rather than their predictive values, you actually realize the volumes are exactly the same. So the FEV1 to FVC ratio is 75% in both cases. The FEV1 is 1.04 litres, FEV1 here is 1.06 litres, and even their TLC, when you look at it, is 1.75 litres compared to 1.62. So it's not that different. What the difference is there's a 20 centimetre difference in height. And this is actually the same person 1 year apart, and they measured their height wrong. So
it worked for me.
Mm-hmm. Yep.
So the pointer worked for me, not working for you?
Not when I use the mouse trackpad. Sorry. But
No,
unless someone can get it to work, yeah. But it's the same person 1 year apart. And what has happened is this is their original lung function, where the technician who did the test measured their arm span. And the previous years we'd been measuring their arm span. And this year, a completely different technician, for some reason, decided to measure height from the bottom to their head, but they were in a wheelchair. And it's made a dramatic, complete difference in how you would interpret their lung function. They've gone from a severe restriction that we were monitoring to something that looked more like asthma. So correct measurement of height does make a big difference in how your lung function is interpreted. Okay, so with lung problems, how do we treat it? Professor Gunton already broached on this. It's really important to prevent infection. So if you've already got squashed lungs, if you've already got lung restriction or poor lung capacity, any sort of infection is going to make you really breathless, might put you in hospital and you become very sick. So you want your vaccinations to be up to date, so flu vax, pneumococcal vaccinations. And if you have other things that can contribute to lung infection, so a big hiatus hernia or even reflux, it's important to manage that, because if you're getting silent reflux into your lungs, it causes inflammation, it causes infection, or it can even cause aspiration pneumonia. If you're getting signs of infection, treating it early is really important. Sputum clearance, my experience in hospital is that physios are very scared and careful in terms of aggressive sputum clearance because of the increased risk of fractures in people with OI. The other important thing that I haven't mentioned here is trying to maintain good bone health, so reducing the risk of vertebral fractures so that you don't get worsening kyphoscoliosis, or preventing rib fractures so you don't get worsening lung restriction is also important. So trying to maintain lung volumes where you can is important. Now the other thing to manage is if they start getting complications of their lung disease, to try and treat that early. So if there's any evidence that you've got any asthma at all, so if you're wheezing or there's a family history of asthma, then treating that with puffers early. And if you're starting to get symptoms of sleep apnea or sleep hypoventilation, identifying that and treating that early also definitely helps maintain lung function. And if pulmonary hypertension starts turning up, treating that as well. So the second part of the talk is just quickly on sleep disordered breathing, which is a fancy name for a condition that is essentially something that causes pausing in your breathing or shallower than usual breathing during sleep. This can be often due to two things. So if you've got problems with your upper airways and they're squashed and they become floppy, if they're floppy enough, you might snore, but if they're really floppy, they might collapse when you sleep, and that's something called an apnea. Or if they're floppy enough and they just close a little bit and you get shallower than usual breathing, and I'll show you some pictures, that's something called a hypopnea. And you can imagine that when your brain starts detecting these underbreathing episodes because your oxygen levels drop or your airways close, you might wake up with a choking episode. This results in lots of arousals or lots of breaks in your sleep. So it causes sleep fragmentation. And if you're getting poor quality sleep overnight, you're going to feel like rubbish the next day. And so you get a lot of daytime sleepiness. And daytime sleepiness for a long time or poor quality sleep for a long time really impacts your quality of life and what you can get out of your day. Sleep apnea is a problem in the general population. In OI, there's different types that sleep apnea can present. It can present as obstructive sleep apnea where your upper airways close. But depending if you've got problems with your skull base and basilar impression, you can also get central sleep apnea from neurological problems because your parts of your brain control your breathing. And if you've got heart problems, that can also cause a type of central sleep apnea as well. And finally, because lung restriction results in you breathing at lower than normal lung volumes, especially if your FVC starts getting less than a litre, you can hypoventilate or underbreathe during sleep because of shallower than normal breathing. And that can result in your carbon dioxide levels slowly going up. So I've already mentioned this, so I won't go over it. But there's starting to be research about whether the constant low oxygen levels in OI in people with sleep disordered breathing can contribute to worsening metabolic bone changes. But nothing's been published yet, or not that I could find. This was just a study where they compared sleep symptoms in those with OI compared to the general population where they were age matched. And what it showed is that everyone was fatigued, everyone was sleepy due to lifestyle or whatever, but people with OI had more sleep-related symptoms, so more snoring. They were noticing, or their partners were noticing pauses during sleep. They were getting more restless sleep, and they had more difficulty concentrating than people in the general population. And so when symptoms like this arise, this is when we usually think about organizing a sleep study. And this isn't something that's just a problem in adult life. They've done studies on children with OI, and their AHI, which is the apneas that I talked about, and the hypopneas all added together, so the number of sleep apnea events in an hour, it starts presenting in childhood, especially if you have worsening motor function. So kids with OI who can't stand up or have an impairment in their walking are more likely to start having higher AHIs compared to those who can't. So you've got the symptoms of sleep apnea. What we do then is put all these leads on your head, bands across your chest, a little box on your chest, and we ask you to go to sleep, which is pretty hard, but it's the only way that we can actually see if you've got sleep apnea. No one's invented a better test. If you do, you'll be very rich, trust me. So what we do is we measure your sleep quality. We measure to see if you're having any obstructive events. So are you stopping breathing or are you under breathing when you sleep? And we also look to see if you've got these funny central events. That is, so you'll have these bands across your chest, and what they do is check for your effort. And if there's no effort, then it's not something that's obstruction up here that's causing your sleep apnea. It's probably a nerve or brain problem. And they might poke you in the wrist and test your arterial blood gases, and that's to see if your carbon dioxide levels rise when you sleep. So this is an example of one of our OI patients who has obstructive sleep apnea. And what you can see, and I don't have a pointer, I'm sorry, but what you can see is on that top row where it says nasal pressure, that's testing how much airflow is coming out of your nose. There'll be a little sensor here sitting underneath your nose. Yes, we'd like to give you things that make it harder for you to sleep. But if you're tired enough, you will sleep. So what this shows is that you can see that the signal keeps dropping off. So it's normal, and then it suddenly drops off, normal, and suddenly drops off. And what's happening is when you're getting blockage of your upper airway, nothing's coming out the front. So that's called a hypopnea. If it was severe enough, it would be called an apnea, because you'd see an almost flat line where there's no breathing at all coming out of the nose because of a sleep apnea event. The bottom one is more severe. So what's happening here is that the flow's dropping off because the upper airway is slowly becoming more and more occluded. And with that, the top red row is your oxygen level. So the oxygen levels are going from 98 to 93 continuously. And you can imagine if you're asleep for a third of your life, so if you get 8 hours of sleep, that's a third of a day, a third of your life. If you spend a third of your life with low oxygen levels, that can cause lots of problems in the future. As I mentioned, we also check for hypoventilation, which is rising carbon dioxide levels during sleep. And this is another person with OI, and what's happening, so this is the CO2 monitoring trace where I've put the arrow, is as soon as they fall asleep, their carbon dioxide levels start creeping up, up, and up. And that's because of their lung restriction. They've got really low lung volumes, and when they go to sleep, those lung volumes drop off even more. If you can't maintain a certain respiratory rate or a certain breathing volume when you sleep, you can't blow off your carbon dioxide levels effectively, and then they start rising. What are the treatment options when we find problems like this? Well, you might have heard of something called CPAP, which stands for continuous positive airway pressure. And what that is a machine connected to tubing, connected to a mask. There's lots of different types of masks, smaller masks that just go under your nose or on top of your nose, or a bigger mask that covers your nose and your mouth. But it works like a reverse vacuum cleaner. Instead of sucking, it blows the pressure into your upper airways. So if you've got narrower upper airways or floppy upper airways, that pressure splints that open and stops them from collapsing. So it gets rid of those collapse events, or it gets rid of those apneas or those hypopneas. And by keeping your airways open and your airways not collapsing, then you're not constantly having those awake events overnight or reducing your arousals overnight. You also might have heard of something called BiPAP, or bi-level ventilation. So CPAP is where there is a single pressure that's given to keep your upper airways open. And BiPAP is different, where it's got two pressures. It gives you one pressure when you breathe in, something called an IPAP, and it gives you a lower pressure when you breathe out. So the difference is, by giving you a lower pressure when you breathe out and a higher pressure when you breathe in, it's sort of mimicking ventilation or mimicking breathing. And what it does is by mimicking breathing, it helps blow off the carbon dioxide levels. So we use that for people who've got sleep apnea with rising carbon dioxide levels. And because we like to do a lot of tests to determine whether you need CPAP or BiPAP, we might do another test with either CPAP or BiPAP to see what pressure you need to keep your upper airways open, or what the best pressure is to keep your carbon dioxide levels normal. And the same person that I showed before, where you can see in the top row, as their flow drops off, so they're having a big obstructive sleep apnea event and their oxygen levels go down, that's the top picture. The second picture shows the person's CPAP study. So we actually put them on CPAP during the night, and what you can see now is that there's no dropping off of the nasal flow. It looks now nice and straight rather than constantly waxing and waning, going up and down, and their oxygen levels remain stable. So this person only needed a CPAP pressure of between 6 and 7 just to keep their upper airways open and stop them from having the sleep apnea events. And we can prove this on a study, but at the same time, after this person started CPAP therapy, their symptoms of sleepiness and poor quality sleep overnight also dramatically got better as well. So I've talked about a lot, so I'll just mention 3 take-home points. In terms of OI, there's lots of different types of respiratory disease, but most of the time they all come in combination to cause lung restriction or low lung volumes. You can also get different types of sleep disordered breathing with OI. It's really important to correctly measure lung function with a correct measurement of height or a correct measurement of surrogate height. And this is the measurement that should be consistently monitored so you don't get weird variations or incorrect variations in your lung function measurements. And sleep study testing is useful, especially if you're symptomatic, and it helps us assess how your lung disease is affecting your sleep so that we can prescribe the correct treatment. Thank you. Any questions? Yes.
Many of us have known that the highest incidence of passing away with OI is lung problems, respiratory. And all of that's really useful, but at the critical stage, when you're in ICU and you've got pneumonia, what do our doctors need to know? You know, the doctors at a base hospital in a regional town, what do they need to know? Because, I mean, if it's, is there a connective tissue issue within our lungs that they need to be aware of in order to treat us more effectively?
Yeah. I think that's hard. If you're really sick and you're in ICU, a lot of the time it's general management. So treating an infection or treating whatever the underlying cause is with antibiotics, or if there's fluid in your lungs, treating that with fluid. But it's really important if they know your history, if you've got any problems with sleep apnea, or if you already have a problem with respiratory failure, so high carbon dioxide levels, then it changes the way they ventilate you when you're very sick as well.
But should we tell them be aggressive?
So
because otherwise it just, apparently we collapse in that sense much faster.
Yeah. So I think if you're starting to get sick from a respiratory problem, you want to be aggressive very early on rather than aggressive later. So you want to hit whatever it is that caused you to become really sick hard really early on. So antibiotics early, whether it's antibiotics tablet-wise or through the drip, and starting ventilation early. So trying to prevent lung collapse from worsening is really important, especially if you ended up in the ICU. So yes, I think if you're going to be aggressive, you want to be aggressive in those first 48 and 72 hours. And I can't be certain for regional centres, but certainly in bigger hospitals such as Westmead, we're quite aggressive in the first couple of days, and then it depends on what's evolved or what we found out after those first couple of days on whether the treatment changes or how we continue.
Just to sort of go on from that, I know I'm very careful about letting sick people near me, because I tend to, like, if they've just got a little cold, I'll end up with pneumonia. But the problem that I sometimes have is I'll go to the doctor and they won't want to give me antibiotics because it hasn't quite developed. So is there anything you can suggest to maybe how we can educate our medical team
having problems, yeah. I think that relies on your general practitioner understanding what's going on and understanding the risk of infection, especially if your lung function is low. So for example, with people with asthma, GPs are really aware of asthma or even COPD, and they've got these asthma action plans or COPD action plans. So what we sometimes do is write an action plan for people with different types of lung diseases that aren't just COPD and asthma to try and educate GPs. And that could be something that you could come up with your GP and your specialist. And in people who are more reliable, often you can give them a script for antibiotics that they can start at home and then see their GP the next day in case you start getting symptoms in the middle of the night.
Yeah.
Yeah. Yes.
I've had pneumonia and it was horrible when I tried to get it out. But should we be able to carry a card to say that we've had pneumonia or that we're liable to this? And so if we carry something like a medical card like that, the doctors, as soon as you feel, like I was in ICU earlier this year because of a bowel obstruction, that was because my lungs were being
Squash your lungs, yeah.
And I've got to sleep with a reflux with my head up and protect my neck. But they're the sort of things we should carry something on a card. And so if we at least say, well, got brittle bones, so these are other complications, instead of having to start from scratch and going backwards.
Yeah. I guess a card would be a good idea, but then if you're really sick and you've ended up in hospital, you have to be able to whip that card out somehow.
No, but you'd have it in your purse with you.
Yeah, but that means that they'd have to look through your purse and look for it. Sometimes in hospital, what the doctors can do is look at your past history and see if you've had recurrent.
When you've been to multiple hospitals
And they don't do
all
that.
around the state.
Yeah.
Or have a good GP.
Yeah, exactly.
And in a complex,
Bristi, we know you have to get away and we've held you over.
That's okay.
Question, question.
Yes.
Sorry, just had a question. So I wore a very tight corset for many, many years. So did you look into lung restriction for people with OI who wore a tight corset? And is it common that causes lung restriction as well?
I don't know if there's any evidence behind that. I guess all I'd recommend is if you're in a brace or a corset, is that you continue to regularly monitor the lung function and see if it's changed. The main concerns are if your lung function starts dropping off and starting to become less than a litre, that's when we'd get worried. But if it maintains and you don't have much in the way of symptoms and it hasn't changed a lot, then that's something that I'd be less worried about. But I don't know if there's much evidence out there about how much more that contributes to lung restriction. Yeah. But that's something that I just continue to monitor over time, if anything.
Thank you.
I think it's been really fabulous having you here, Bristi, because that was one of the questions that we had certainly last conference, and it comes up time and time again. And I guess for me, as a society, what we need to do is take action about getting some of these documented down so that you do have something to take to your GPs or to the hospitals if you're there. Make sure that it's on your national health record. That's what it's there for. So it doesn't matter which hospital you go to, it should be there. So this is the sort of stuff we need to be really proactive about ourselves to make sure people know about it and make sure that you have your vaccines and the like. So and that your peers know about that. Thank you very much for coming in. And I know we do need to get questions on it. Once we get down to your morning, so there's a wedding to go to.
It's not my wedding.
But then we would be overly Thank you very much for taking the time. Really
not a
appreciate it.
problem.
And I won't pull them all out because it is actually quite
Okay, thank you so much. Yeah.
enjoy that. Thank you so much for that.